Good afternoon. Thank you for coming to today's Clinical Technology and Health Services Research Rounds. Today we're very privileged to have Dr. Rohan D'Souza speak to us. You can see here Rohan's qualifications, and he may be the first speaker we've had with more letters after his name than there are letters in the alphabet. So well done, Rohan. That may not be true, I don't know. I was on Rohan's thesis committee, and so I know a number of things he's been doing and continuing to work on. Amongst the things he's going to talk about decision analysis in obstetrics, and some of the specific topics I know that Rohan's interested in are increasing safety and success of vaginal birth following labor induction, assessing the use of tranexamic acid preventing postpartum hemorrhage, in general improving pregnancy outcomes in women with medical disorders, and all these seem like they'd be great topics for decision analysis, and that's what you're going to be talking to us today about. And would you like questions as you go, or would you like to save the questions to the end? To the end?
Yeah.
Okay. Thanks.
Oh, how do I move it?
The title is not working because of this.
Oh, that's okay. But I point to. Well, thanks, George, for that warm introduction. I still haven't collected all the degrees I want to collect, so there might be more the next time you see me, or not. And thank you all for attending this afternoon's round. So, decision analysis is something that some people are familiar with, some people do all the time, and some people have never heard about. So, just one show of hands so that I know from this audience what your level of appreciation or understanding or involvement with decision analysis is. So how many of you would consider yourselves proficient in the use of the understanding of decision analysis? Excellent. How many of you have never heard the word decision analysis before, or think it's some kind of spaceship or something else? How many have never heard of it before? And how many have got some idea but really don't know what decision analysis is about? Right, so I expected that, and that's why it's been really difficult for me to try and decide on how to really structure this talk, because it's going to be too basic for some, and it's going to be too advanced for some others. And so what I try to do is I try to cover a lot of topics so that everybody will gain something from it. So without much ado, everyone has probably seen this pyramid in some form or the other. It's called the hierarchy of evidence-based medicine, and whether we like it or we hate it or we're indifferent to it, you can't escape it. It's always there. And when you look at this, you normally have at the top of this pyramid randomized controlled trials and systematic reviews of randomized controlled trials. Can anybody spot decision analysis on this pyramid?
So you connect around at the very bottom of the pyramid.
Right. Good observation. Yes, but can anybody spot decision analysis on this pyramid? So if this is not even the lowest form of evidence, why are we even talking about it? Why do we talk about decision analysis if it's nowhere on this tree? Even editorials and expert opinions have made their way to this tree, but we don't really have decision analysis on this tree. So where does decision analysis really fit? And if it doesn't fit, shouldn't we all be aspiring to do randomized controlled trials for every and answer every question? Now, I'm not going to talk about all the limitations of clinical trials, but I just want to highlight the importance of doing decision analysis and where it comes to play. So let's talk about some basic limitations. Let's say that there is a condition that that's under study, and you want to test two treatments, treatment A and treatment B. And you decide that your outcome of interest, the outcome you want to study, is a composite outcome of death or serious morbidity, right? Treatment A, 20 out of 1,000 have that composite. Treatment B, 100 out of 1,000 have the composite. What do you think is the preferred treatment? What should be the preferred treatment? If I tell you that's statistically significant. Anybody? So 20 death or serious morbidity out of 1,000 in A and 100 in B. Which is the better treatment? A, right? Now, on the face of it, that's what it seems like. But now if I go further and I say that the treatment, these were the major morbidities that were considered in this study. And this is a real thing, okay? So the numbers might not be, but these are the composites. So major bleeding requiring blood transfusion, reoperation or admission to the intensive care unit, those were the serious morbidities, and then there was death. Now look at those numbers. And after looking at these numbers, now tell me which one do you think is the preferred treatment? Anybody? Still A? So in B, nobody died. In A, 15 died. Right? So when you look at the composite, initially it just seems like, yes, A is a better treatment, but there's so much that goes into what outcomes we consider, how we consider, etc. So this is one example. Just park that thought. Another thing is we tend to look at, in clinical trials, we need a primary outcome, which is a very important thing, which is what we base our whole study on, our sample size calculation on, etc. And this primary outcome is decided by a team of experts that conduct this trial. Let's look at, if our primary outcome is harm, let's look at treatment A. If we say that out of the 1,000 cases or participants, 5 had some harm, and with treatment B, 50 had harm, but in treatment A, 0 had any benefit, and treatment B, 500 had benefit. Now, what would you say is the preferred treatment? What I'm trying to get at is that it's not as black and white, as clinical trials are not as simple, or they're not as black and white as we make them out to be. So let's consider the harm. The harm could be death, or the harm could be a skin reaction. Right? Similarly, your benefit could be a marginal improvement in blood pressure, or your benefit could be the absence of a serious disability. So depending upon how severe the harm or the benefit is, your answer about what is the preferred treatment is going to be different. Another thing, in obstetrics, the trials are not very often done. I'll explain to you why in a little bit. But you sometimes have so many modalities of treatment. Now, if you want to treat somebody with epilepsy, these are the current number of treatments that we have. If we had to start inviting people to participate in a trial and start having comparisons between all these arms, it's not going to be in our lifetime or in the lifetime of many generations after us that we will have an answer from randomized trials as to which is the best treatment. Right? Lots of options. So when most trials have 2 arms, some can have 3 arms, some can have 4 arms, but as the number of arms increases, we know that the power reduces and there are statistical problems, etc. So what I'm trying to get at is that when you've got to compare so many strategies, it becomes difficult to subject participants to a randomized trial or a clinical trial. Some people would say, do individual trials, and then let's do indirect comparisons by using something called network meta-analysis. And some people probably are aware of what that is. But for that, you first have to do the initial randomized trial. And it is very hard to do randomized trials because these patients are few and far between. Now, introducing the concept of obstetrics, for those of you who are not aware, obstetrics is the study of, I didn't know that had. That's a live baby and a live mother. So obstetrics is the study of pregnancy. So it's about a pregnant woman and a live intrauterine fetus. Now, most will think it's just one other part of medicine. So why are we making such a fuss about obstetrics? Remember, in obstetrics, we have 2 distinct individuals. They are independent individuals. They are very intricately related. Right? The other thing to remember is that any decision that is made in pregnancy has implications to the lifetime of both the mother and the baby. Third, only one person really makes the decision in obstetrics on behalf of both of them. And very often, there are competing interests. Now, I'll explain to you what competing interests are, but in a nutshell, generally, whatever is good for a mother tends to be not so good for a baby. And whatever is good for a baby tends to be not so good for a mother. So how are you going to select what outcome is important? If you ask a neonatologist, their set of outcomes are going to be completely different from an obstetrician. So when you have competing interests where something is very beneficial to a mother but not so good for a baby and vice versa, then you have a bit of a conflict. So I'm going to give you an example of anticoagulation in pregnancy. It's a busy slide, but I'll take you through it. Let us assume, so anticoagulation basically is blood thinners in pregnancy. Let's say we have 3 options. The first option is warfarin or vitamin K antagonists, right? The advantages of vitamin K antagonists in a certain subgroup of individuals is that if a person has got an increased risk of a blood clot and the person has warfarin or vitamin K antagonists, they are at the lowest risk of having maternal death, right? They are also at the lowest risk of having thromboembolism. So if you look at that side of the story, it seems like, yes, that is the best treatment to give a person. But what are the disadvantages of vitamin K antagonists? They cross the placenta. The fetal loss rate is about 33%. The fetal malformation rate was in the literature quoted at between 3.7 and 6.4%. And there is an increased risk of bleeding. Right? And so although there are the lowest risk of clot and death in the mother, there are some other disadvantages. Heparin, on the other hand, does not cross the placenta. So the fetal risks, they were not documented earlier on, they now are. They were possibly much lower. There are no drug-related malformations because the drug doesn't go to the placenta and to the fetus, so that was a good thing. And there is a reduced risk of bleeding when they're given heparin, but the risk of maternal death is higher from clots, and the risk of thromboembolism is about 13.4%. Right? So in order to try and balance things out, what people did was they said, why not give heparin during the crucial part of the baby's malformation, that is the first trimester of pregnancy, then give warfarin to protect the mother, and then give heparin again at the end when she's at a risk of delivery and bleeding at the time of delivery. That's called sequential treatment. Theoretically, that's a very, very good option. But in practice, we see that every time there's a transition from one system to another, there is a risk to both mother and baby. Okay? So these are the three treatment options that a person, that clinicians are faced with when we need to anticoagulate a person. Now, there are so many outcomes to consider in obstetrics. There are outcomes that are related to the mother, and there are outcomes related to the baby. So for somebody receiving anticoagulation, the risks to the mother are the risk of death, of thromboembolism, which is a blood clot, of bleeding, of having cardiac events, and of having adverse events to the drug. All of these are important events and need to be considered. But then you also have perinatal problems, so the problems to the baby, and that includes perinatal loss, which is a miscarriage, stillbirth, neonatal death. There could be a risk of fetal bleeding into the baby's brain, which can have lifelong consequences. Congenital abnormalities in the baby, like a specific abnormality from warfarin, or other congenital abnormalities. Right? Which one of these do you think are important? Which are the ones that we should be considering? Now, the reason I mention all these things is because doing studies in obstetrics is not that straightforward. It is not straightforward for these reasons. First of all, we have to often make decisions between a number of treatment modalities. The second is we need to consider numerous outcomes, not just one. And these outcomes are not just related to the mother and baby in pregnancy, but to the lifetime of the mother and baby. The third is the competing interests. Like I said, some drugs cross the placenta, bad for baby, but good for mother. And some drugs don't cross the placenta, but so competing interests. How do you deal with that? And from the first two examples that I gave you, you'd probably be able to appreciate that outcomes are not just about how many outcomes occur. Right? So when you say death or composite, when you look at the composite outcome, it seems like treatment A was the better one. But it's about what value you assign to that outcome, because some of those outcomes are not as, in our mind, serious as another. So clinical trials will tell you event rates. They will not tell you about the value that's assigned to that outcome. And those values could be either in the form of a patient preference, or it could be in the form of cost. Now, the other problem is, it's not a problem, it's a good thing. Serious adverse events in obstetrics are actually rare. So in Canada, the number of women that die during pregnancy is 6 in 100,000. So if you wanted to see death as your primary outcome, because it's the single most important outcome, you would have to randomize several 100,000 people to see a difference, and that's not possible. And therefore, we use composites. But again, composite adverse outcomes are rare. Right? And so we tend to mix things up. And so clinical trials have their flaws or limitations in obstetrics. The other limitation is it's very, very difficult to recruit a pregnant woman to a trial. Try telling somebody who's pregnant, I'm going to try this experimental drug on you, and let's see what happens. Right? Nobody is willing to take the risk because there's so much at stake. So clinical trials are not that easy to do in obstetrics. Now, talking about anticoagulation for pregnant women in mechanical half valves, one of the things we thought we would do is, this is a very high-risk group of women. One of the things we thought we would do is do a systematic review of all the literature that there is and see what data is out there. So we did this systematic review, and what we found was this busy table. And if you think this is busy, wait till I show you the next one. So this table has got 4 outcomes that we consider. So there's maternal mortality, thromboembolism, that's blood clot, live birth rate, and anticoagulant-related fetal abnormalities. And there are 4 treatment options. There is the VKA that I talked about. There is sequential treatment. There's low molecular weight, which is one type of heparin, and then there's another type of heparin. Now, I'm not going to ask you to go through this entire thing, but you will see here that as you go down here, the maternal complications reduce with these four, the complications increase. The maternal outcomes are always best with vitamin K antagonists. But when you look at the live birth rate and the malformation rate, they're always going to be best with heparin. You see that? So, looking at the top there, maternal mortality is 0.9%. You look at this row there. So it increases from 0.9% to 3.4% as you go down that list. But look at the fetal malformation rates. It goes in the opposite direction. So ultimately, by doing all the synthesis of the literature, the only thing that we come to a conclusion on is that so-and-so is better for mother and so-and-so is better for baby. But how does this help a clinician and how does this help a patient? Right? So you thought it was a busy table. This is one of the busier tables on that paper. And the reason for that is even within vitamin K antagonists, outcomes are different if you have a different INR target, right? It's different between if you're using unfractionated heparin in the beginning or later. There are so many permutations and combinations. So answers are not simple in obstetrics. So far, how do we do joint decision-making in obstetrics? Physicians present patients with all these numbers, and we tell them to come to a decision. So we present to them those busy tables, and we tell them, now you tell me what you want, because there's no real recipe for complete success. So do you think death is worse and clot is worse, or bleeding is worse, or do you think your death is worse, or you think death of baby is worse? You know, I'm trying to simplify it, but that's essentially what you say. You present these numbers and tell them to pick. Now, when we do that, we assume that patients understand those probabilities or those numbers. And we presume that they understand the trade-offs of those competing risks and the interactions between the positive and the negative outcomes. We assume that they are able to assign values to those probabilities and make those decisions. And then we assume that they're able to understand those probabilities, which is those event rates, and the value of the event rate, and put it into a computer somehow and tell us, yes, I think this is the right thing. So we make all these assumptions. But the truth is, people don't really get numbers. If you look at, now all of us have gone to university and we are generally a very privileged part of society. We understand, we're literate, we understand numbers, etc. But people out there, there's not a lot of people out there that really understand numbers. And the reason I went into doing this was because I once had a patient who shocked me. And she was in clinic, she was at a very, very high risk of death in pregnancy. She had a 50% chance of dying in pregnancy. She was told that she had a 50% chance of dying in pregnancy. And the decision was made to terminate that pregnancy early on so that she wouldn't be at that risk. So she opted to have that termination. She was on the operating table for the pregnancy termination. And when the physician asked her, do you have any questions? She said, you know, I'm being coerced into this, don't you? And so the physician said, we're stopping here, get off. She said, no, just go ahead and do it because, you know, I'm not going to go back to this clinic. And she said, no, there's no way I'm doing this if you think you're being coerced. So he called me because I was in clinic that day, and she said, can you just have an independent consult with her? I'm definitely not doing this procedure today. Just have a discussion with her. And so I had this discussion with her, and I said, can you tell me what you understand of your risks? And she said, 50%. I said, what is 50%? So she said, I've got a 50% chance of dying. So I said, yes. And do you think that is high? I said, so she says, well, I've always had this risk of dying. It's no big deal. It's 50%. So I said, what does 50% mean to you? And she just said, it's like 50 people will die. And I said, 50 out of how many? And she said, well, 50 people will die. And this is a true story. And I said, okay, let me try and explain this to you another way. And so she was there, her husband was there, and I said, let's assume that you are in this room with this condition, and in the next room there's another person with this condition, the same condition. Now, by the end of these 9 months, one of you will be dead. And she said, that's not possible. That's not 50%. I said, 50% is 1 in 2. And she just couldn't get it. And now when you see why people put infographics, etc., it's because people do not understand percentages that are that simple, like 50%, some of them. And we are talking about 0.9% versus 2.9%, and thinking they would be able to make a decision. You're presuming a lot. When we looked at literacy, so literacy is already a problem. Numeracy is even worse. I won't go through all of these. There are very interesting articles from between 2016 and 2019. And you can try and find Canada there. In terms of numeracy and literacy, people are really in Canada not able to understand numbers. They're not able to understand simple numbers, simple equations, simple proportions. And then when you throw numbers at them and say make a decision, we're making an assumption that they really understand, and they don't. Many of them don't. So let's get decision analysis. How does decision analysis help with all of this? I'm not going to go into the details of decision analysis, but one of the important things that decision analysis does is it allows not just the consideration of the event rates or the probabilities of events occurring, but also of quantifying the values assigned to those events rates and putting that together in decision making. It's probably the only well-developed prescriptive framework when one has to make a choice under uncertainty. And in pregnancy, it helps to support the complex decision making, which involves two patients and competing interests. And I'll try and show you how. The same example of mechanical heart valves and in pregnancy. What we do in decision analysis is, for those of you who are not familiar with it, you're able to compare a number of strategies. Because it's modeling, you don't have to get patients through it. You simulate and you do modeling on the basis of numbers. You look at all the possibilities of events occurring along the pathway. So if this person took vitamin K antagonist, the person would either be alive or dead. If this person was alive, either have a blood clot or not have a blood clot. If they have blood clot, either have a fetal loss, not have a fetal loss. So you create this tree with all these different probabilities in that tree. Now, you can put in the numbers for this particular treatment of all those events happening. And the good thing is you can add, so you end up with all those different kind of health states. And then you can add values that patients assign to those health states. And so what you have in the end is when you, what is called rollback, you get preference values. So you get what is called the expected utility of this entire arm. So considering the event rate and the value assigned to the event rate, which would be the best treatment. And so you can use expected utilities and quality adjusted life years if you consider life expectancy. So I'm not going to go into the details of that because you really can't learn decision analysis in one class. I realized that over 4 years of doing my PhD, I still don't know how to do it. So it's not going to happen in one class. But essentially, this is the basis of it. So you see how decision analysis can work. You can consider so many outcomes. You can consider so many different treatment strategies. You can look at the event rates and the probabilities assigned to those event rates. So we did a study on whether decision analysis is being used in obstetrics or not. And this is a graph that shows how decision analysis has been used over time in obstetrics and gynecology. And that is for management of conditions, prevention, and screening and diagnosis. And it's being used increasingly. So in the 1980s and 1982, there was one paper that was published per year. And now there are so many, 45 papers per year on decision analysis. So it's becoming a big thing in obstetrics and gynecology. When you look at only the management of conditions, you can see in gray, the lighter color are the abstracts and the publications exponentially increasing. Everybody's doing decision analysis because it's cool. It's a cool and trendy thing to do. Most of these studies are being done in the US, but there are other countries that are catching up as well and doing decision analysis. So if everybody's doing decision analysis and it's all hunky-dory, why are we here? Why are we talking about it? What we did when we looked at, we wrote this paper on decision analysis in perinatology, and what we identified was that people were using it, but people were not taking into account the problems that there are with this mother-fetus dyad. Obstetrics is a unique condition, so just because something worked in anticoagulation and mechanical heart valves outside of pregnancy, you can't extrapolate the same rules or the guidance to pregnancy because it's very, very complex. Now, that's a busy table again. But essentially what we found was decision analysis models were very often considering only the mother or the baby, and that can't be right. So we looked at one condition, which is how do you treat somebody or how do you manage someone with a previous cesarean section in her next pregnancy? Should she have another cesarean section or should she attempt a natural birth, right? So that's called a TOLAC or a trial of labor after a cesarean. So which one is the better thing? We looked to see how many decision analysis models were done. There were 13 decision analysis models, looking at the same question, same population, same outcomes. Now, if this is science, the results should be the same, right? What do you think the results said? 6 of the papers, so 4 of the papers said everyone should have a repeat cesarean section. 3 of the papers said everyone should try a natural birth. And the other said depending upon what the threshold of success of your vaginal birth is, it could be this, but over either 48% chance to 74%, I remember these numbers very vividly, a TOLAC might be, or sorry, an elective cesarean section might be better. Now, how is it possible that you get 3 different answers to guide clinicians about the same condition when you're looking at the same pre-production? The reason is some of them only looked at it from the point of view of the baby. Yes, for the baby, the best thing is to do a cesarean section. If you're looking at short-term goals, right? The baby is well. Do you make an incision on the uterus, get the baby out, baby's in perfect condition. Baby goes home. Labor has got its risks. But if you have to consider the lifetime implications of something, then things change. From the mother's point of view, a vaginal birth is definitely going to be better if it is successful. But if it's not, and the uterus ends up rupturing, then it's terrible. So it depends upon, so some of these models looked only at the mother, some only looked at the baby, some looked at only the short-term implications, some looked at the long-term implications, and some added costs. So depending on what you do, there can be a lot of variation in how you guide clinicians. And clinicians are not, I'm a clinician, so I can say this, are often very busy and also not very, very clever when it comes to making decisions. We like to look at the conclusion of an abstract. What does it say? Because, oh, there's a new paper in the Lancet. Did you read that paper? What we mean essentially is, did you read that conclusion? So the conclusion says elective cesarean is better. What do you mean by better? Well, I don't know. It's just better. It's better than TOLAC. For who? On what basis? Those that the fine print is often not read. And so before we make decisions, and this is what we're guiding, and that's why clinicians are always, I hate research. Last year they said this was better. This year they say that is better. The thing is, nobody goes to the bottom of what is the meaning of better, and on what basis do we make those decisions. So in a nutshell, what we did was we tried to look at what these problems are with this, the decision analysis studies that are happening. And we came up to some conclusions, and the most striking conclusions were these, that you need to consider both the mother and the baby. You need to consider the preference values of these utilities, or the preference values of the utilities. We looked at the different methods of obtaining these utilities or preferences, and we talked about the benefits of one certain method called the standard gamble. We looked at, should you be getting preferences from people that have the condition or don't have the condition and are just pregnant, or should it be a combination of both? We looked at that. We tried to address the issue of the family member, and I'll get to that in a bit if there is time. I don't know how should keep track of
yeah, half an hour.
It's half an hour now? Okay. So just stop me when you're bored, and then we can ask questions. But and then we also said, in terms of comparing strategies, what are we going to do? How do we compare strategies? Can we use this term QALY, which we normally use in decision analysis, to in obstetrics to represent the mother and the fetus? So these are the various issues that we try to address through this. Now, the benefits of decision analysis in obstetrics are that we can compare those multiple strategies, look at the multiple outcomes, deal with these trade-offs, incorporate not only probabilities but also event rates. We can add life expectancy, which is very, very, very important. Remember that if you make a decision in obstetrics that results in birth asphyxia to the baby gets cerebral palsy, which the baby takes with it to its death. And so the consequences of a decision made in obstetrics, which are not made by that individual, but by the mother, can last a lifetime. So taking life expectancy into account is really, really important in obstetrics. And the other good thing is it lends itself to cost effectiveness, cost utility analysis. The problems with decision analysis, and these are the general problems, it's like you put some things in, you press a button, and then the computer spits something out. And not all of us are comfortable with that. It's like, how does that happen? What are all these numbers? What does all this mean? And so the black box model thing, the clinical complexity of situations, every person's situation is slightly different. And even when you're looking at outcomes, when you talk about cerebral palsy, there are mild variants and there are very severe variants. When you talk about bleeding or clots, there is something that results in just a clot in the leg and then goes away, and there's a clot that could result in stroke. So the clinical complexity might not always get captured in decision analysis. We make a lot of assumptions and extrapolations. And the verisimilitude is about the appearance. It's got the appearance of being real or true, but is it really real or true? There's this question about, where do these utilities come from? The utilities obtained from the population, is that relevant to the patient who's sitting in front of me? What if her values for the same condition are different? And then again, the concept of the problem is prescriptive or descriptive tension. So in the sense you put these numbers in and then you tell a patient, I did a decision analysis study, this is what you need to do. It's not easy in clinical practice to try and explain something like that to someone. But the other problems that are specific to pregnancy are, what health states should we consider? Should we consider mother's health state and baby's health state separately, or should we consider combined health states? The other question is, how do you measure these preferences? What kind of instruments do you use? And what is the role of using indirect utility measurements like the EQ5D, which many people use in other areas? Can you use that in obstetrics? And finally, whose utilities? Are these the utilities or the preferences of the mother? What about the family member or the spouse, or the partner, or the other person involved in decision making? And what about the preferences of the baby? And finally, how do you deal with QALYs, or quality adjusted life years for pregnancy? Whose life expectancy are we considering here? There are two individuals. How do you deal with expected utilities and QALYs for two individuals? Right? So, in order to answer these questions, I set out on a PhD. That's the reason why I've got all these degrees, because I keep coming up with questions and then I want to answer the questions, and that's what happens. So we did 3 studies, and 3 of my committee members are here in the audience. So what we did was we first started off by doing a systematic review of all these decision analysis models. The concern is that people are doing a lot of decision analysis models in obstetrics, and they're spitting out answers or solutions, and those answers might not be valid. We might be doing more harm than good if we don't do these models right, and therefore it needs to be arrested, and we need to find the right way of doing this. So we did that, and then we looked at how...
Please, the overhead paging will be down for about an hour.
Right.
Please refer to your pagers.
So the second study that we did was to look at how preferences have been elicited in obstetrics. How do we do that? And finally, we decided that what we were going to do is we were going to do a study in order to try and elicit preferences from mothers for these health conditions. So the first study is the systematic review where we found 77 papers that had looked at management of various conditions involving a mother and a baby. What we found there was that 53% only looked at both mother and baby out of these decision analysis studies. Only 47% actually used preference values. So people are doing decision analysis studies not looking at preference values because it's so difficult to get preference values. Whose preference values? Answering all those questions. Only 13% of these studies actually considered outcomes over the lifetime of the mother and baby. Only 25%, this is more economic evaluation, actually described a societal analytic perspective. And those are all more, the latter part of it will make more sense to the ones who have done decision analysis. But in terms of systematic sensitivity analysis and discounting, there were so many flaws in the way people were doing this. So the answers that we're getting are not really always valid because there are problems with the way the studies are being done. So the key conclusions we drew was that despite the long-term implications of obstetrics decisions to mothers and offspring, these models did not often consider the lifetime horizon of mother and offspring. They did not include preference values for mothers and offspring's health state, and they did not adhere to the basic guidelines that have been published on how decision analysis studies need to be done. We then looked at preference values and a systematic review of preference values. How are preference values being elicited from people? There were 37 studies that looked at how do we get these utility values or the preference values. And there were 23 studies that were done explicitly to get utility values using different methods. And 14 of them were done as part of a decision analysis model. So I want to plug a decision analysis. I want to do a decision analysis model. I want to put utilities in. How do we do it? Why don't the 5 of us get together and throw in some utilities? Literally like that. There were 8 people sitting in a room. What do you think the value of so-and-so is on a visual analog scale? Right? So there is a big variation in how utility values are being obtained in obstetrics. So median number of participants was 125. Some studies had 2 participants. So 2 people sat around a table and came up with a utility value, which was the mean of the 2 and the range being between the lower value and the upper value of the 2 people in the room. And there were some others that looked at 4,016. So, you know, this term that says garbage in, garbage out, what you put into a decision analysis model is really, really important if you're going to rely on those results, right? This is the value or the state of preference values in obstetrics right now. And so the key findings were that there are inconsistencies with regard to the choice of the evaluation methods, who the respondents are, the sample size specification, and also the choice of upper and lower limits. For those of us who know what utilities are, we anchor them between two things. One is dead, and the other is perfect health. And so all values get anchored between 0 for dead and 1 for perfect health. But in these studies, they didn't do that. In many studies, they said, why don't you say that the upper anchor is your best possible health state, and the lower anchor is your worst possible health state? That changes everything, right? If you don't anchor them on dead and perfect health, the values are very, very different. So these are some of the other problems that we found with the decision analysis studies. I'm not going to go into the details of these conclusions, but essentially what we found was that we were able to create a repository of all utilities. That is not difficult because there are not so many. So all the utilities used in pregnancy, and we also highlighted variations in the methodology and the challenges with regard to the conduct of these studies. And then we went on, sorry.
I don't have time, I'm sorry. 20 minutes.
20 minutes? Okay. So then what we did was we said we can't solve the whole world's problems, at least not as part of my PhD, because this was already running into the 4th, 5th year. And so we said we will stop somewhere. Let's try and solve the one big problem, which is how do we get utilities for the health aids, and then we'll solve the other problems later. So what we said was we're going to use the lessons that we learned from the first 2 studies in order to inform how to conduct preference studies for maternal-fetal health states. Remember, when we use utilities from the literature that do not involve a combined health state, there can be a problem, and I'll tell you why in a minute. So what we said was we're going to compare preference values for combined maternal-fetal health states. And I'll tell you what a combined maternal-fetal health state is. It's not about what is the value a woman would assign to a blood clot. Is blood clot bad? Yeah, it's bad. Is bleeding bad? Yeah, it's bad. But is getting a blood clot or risking getting a blood clot in order to have a live baby bad? The answer, they're 2 very different questions, right? So if you do not consider a combined health state, a state between a mother and a baby, and then you just use the utilities that are in the literature for clots, you're going to get completely different answers. Right? It is important to consider that as a unit, because when a woman is making a decision, she's making that decision based on, yes, this is the risk I'm taking in order to get that benefit. Right? So that is the value of the combined health state. We also had this question about, should we just do mother's preferences? Should we do partner's preferences? Should we do their preferences together? Those of you who do utilities in pediatric populations, you know that it's mother and father together, or both parents as a unit that make decisions. But in obstetrics, the fetus is considered part of the woman's body until the fetus is completely expelled, right? Completely delivered. So does the father or the partner have any role to play in decision making? And that we can have that debate until the cows come home, and people will always feel strongly one way or the other. But and which instrument are we going to use? So we did a cross-sectional study here in Canada at Mount Sinai Hospital. We looked at pregnant women that had the condition, that means that were taking blood thinners, and people that were naive to the condition, not taking blood thinners. And we wanted that combination, and I'll tell you why in a bit. We looked at family members involved in medical decision making as well. So we wanted to try, and all the problems we identified in our systematic review that was not there, we tried to address. So that's what I put in green boxes. We wanted as diverse a sample as possible. We didn't want all well-educated Caucasian women. We wanted people that were the whole spread. We wanted people from different religious backgrounds, ethnic backgrounds. We wanted people that had a prior experience with the condition and those that didn't. If you ask a diabetic woman, how bad is it to test your blood sugar every day and to take insulin? Her answer is very different from if I ask Ali there, what is your preference value for taking blood sugar measurements every day? So you want that range. You want to know the range from everyone. And then we try to address the role of the family member. We first interviewed them separately, that is family member in one room, patient in another room, and then we got them together to do the same tree test. We looked at scenarios which described various maternal health states and fetal health states in combination. So the maternal health states were perfect health, having a blood clot or dead, and the fetal health states were perfect health, a minor malformation, major malformation, or dead. And we looked at the lifespan of both. So we looked at physical, mental, social, emotional health of both over the entire lifespan, because it is not just about giving them a certain condition. And we looked at 3 instruments, which I will not go into details. And this again addressed some of the other issues that we found in our systematic reviews. We compared 7 of these combined health states. We compared answers from these respondents, and we compared these 3 instruments. These were the 7 vignettes, and this was a sample vignette. Just to try and explain to you, this is mother has got a blood clot, baby has a major malformation. So you take, they had to spend time reading it and understanding what this really meant. And it talks about your baby might have multiple visits to the hospital throughout the lifetime. This baby might not be able to play in school. The baby won't be able to. It's the whole thing. It's not just about your baby has a major malformation. So they went through all of this and they made these decisions. In terms of utilities, and just in the interest of time, we got 57 pregnant women, 43 members, and we had a total of 40 pairs. And so we got answers from all these, and we ran an analysis of this. Very, very population. 37 of the 43 family members were spouses. Some of them were not. Boyfriend, mother-in-law, mother, sister. So some were single women. And then most of them were married, but some of them were not. Some were in relationships for just about 1 year, and some 22 years. So what I'm trying to get at is this was a very diverse population. It was not just a homogeneous population. Most of them were, of course, born in Canada and of Caucasian descent, but there were people born everywhere, and so a diverse population, like I said. The result, I'm just going to ask you to focus on the last part of that graph. Okay? On that last part of the graph, what we see is on the x-axis is the utility values from 0 to 100. That is what is the preference value for that condition. And on the y-axis are the 7 malformations. And those are the 3 instruments. Let's just focus on 1 instrument for now. In gray, or in dark gray, you see the preference value assigned by a mother. In blue, you see preference values assigned by the family member, and in yellow, you see preference values assigned when they're sitting together. Right? Now, you don't have to know very much about how to analyze a graph, but isn't it surprising that the values assigned by the mother are always lower than the values assigned by the family member, right, for the same condition. And when they sit together in a room and discuss, the values that they assign is closer to that of the family member and not closer to their values. So we take so many things for granted about who should be assigning utilities, etc. And the details of why this happens, etc., is something that we're exploring in a qualitative study right now. But there's so much we do not know. Pregnancy is not just it's a condition, it's a social construct. Nobody makes decisions in isolation. So getting a woman into a room, caging her into a room and making her make a decision on something is not how pregnancy normally works. She talks to her partner, she talks to her mother, she talks to her pastor, she talks to the blogs, she talks to everybody and comes up with a decision. So if you're getting this preference value, should it not be reflective of the real world? So whose preferences should they really be? So this was one of the things that we identified there. So the conclusions of that study were, we felt quite strongly that if you wanted to obtain utilities, we need to obtain utilities for a combined maternal-fetal health state and not for mother states and baby states separately. We need to consider shared interviews between pregnant women and people that are involved in the decision-making. And for reasons that I'm probably not going to be able to cover right now, the standard gamble is the instrument that we should probably be considering for use in obstetrics. And I'm happy to answer questions on that after it's finished. So, number of limitations. Like I said, I could not solve all of the world's problems, but I think what we were able to do was to come up with some very clear guidelines on how preference values or utility should be obtained for decision analysis studies. And there still is quite a bit of stuff to be done. This is the same graph that I showed you at the beginning about my PhD work. So I completed those 3 studies. But what we now need to do is we need to start working on an international consensus group to address the remaining problems that there are with conductive decision analysis studies in obstetrics. There are a number of issues that need to be dealt with. How do we tease these problems out with decision analysis and patient preferences in obstetrics? So in conclusion, decision analysis studies are being increasingly used for clinical and economic evaluation studies where clinical trials are not feasible. The advantages are that you can compare, you can use head-to-head comparisons between so many strategies, include so many outcomes, incorporate preference values for these outcomes, compare outcomes that are patient-centered, and you're able to do an extensive sensitivity analysis to come up with lots of, so understand all the variations. But the biggest gap has been, in the conduct of decision analysis studies, has been the lack of valid utilities. And I'm hoping that through the work that we've done, at least some of that is being addressed. However, there still are a number of issues that need to be dealt with in terms of how do we make this decision analysis amenable to cost effectiveness or economic evaluation studies in the future, and issues surrounding the quality. So those things need to still be addressed. And so there is a need for a consensus meeting, which I'm hoping that we should be able to start with all these bright minds in the room. There's a lot of interest around the world in doing that, and so hopefully we'll come up with some more solutions as to how this needs to be done in the future. So I'd like to acknowledge a lot of people that are in this room. There were part of my supervisor, THETA, here, my committee members, Murray and George and Karen. And yeah, so thank you very much. And I'm happy to take any questions.
We have one question from the online audience. Sean is asking, some researchers suggested that there are some ethical concerns of estimating the lifetime cost of infants given disease conditions. Is it the main reason of not conducting lifetime models?
Right. So the thing about lifetime models and the fetus is something that neonatologists have had a problem for two things. One is so if a baby dies, the lifetime of the baby, when you make a decision at the time of birth, for example, a miscarriage, it suddenly trumps everything else. Right? Because death is zero, so it kind of trumps everything else. And so we are hesitant. I don't know whether Murray has an answer to that, or anybody has an answer to that. But yes, it is because death trumps almost everything when you consider it so early on in life, in pregnancy, that none of these models make sense because if there are more miscarriages in an arm, suddenly that arm is just not important, but that's not really reflective of the decision that people make in real life. You know what I'm trying to say? I don't know whether I was clear enough. Why do you have anything to add?
Well, I think it's mainly the problem with the quality model. I think our implicit social values are, if you have a mother and a child, their lives are both important, but the mother's life is more important. And I think that's the principle that guides clinical decision making around care and obstetrics. If the mother's life is threatened, that trumps the baby's life. And yet, as you say, if you use a quality kind of framework, the child has a greater number of qualities at play than the mother does. Mm-hmm. So you've got a dissonance between what the quality model says and what our implicit social values are with respect to the relative values of those lives. So I think it just speaks to the fact that the quality model in this context is probably not adequate. It's one of the potential circumstances in which the quality model is dissonant with our social values with respect to life and health.
Yeah. Right. And that is true, but it can also be addressed in the fact that I was talking to Marina yesterday, a couple of days ago, and we were just talking about, if you take the combined health state, which includes the preference value for the fetal outcome along the lifespan of the fetus, you still can get qualities from the maternal perspective.
Well, you can, but what you're doing when you get a utility for a joint outcome is you're not making any assumptions about the relative importance of quality, length of life. You're rolling up all of the dimensions of outcome in a single utility value. So you are much less constrained to particular judgments about the importance of life expectancy and quality of life.
Yeah.
I think we've discussed this for one day, but I guess the way that you set up the study, it really looks at quality utilities for the woman. Like, how does the woman assess those combined health states? And it still ignores the baby. So in a model, you still could add utilities or preferences for that baby, for whatever the disease is. So I think the way we ask the questions instead of giving yes, it's really how does the mom feel, or the mom and the partner, about having a baby with a major disability, right? And it's not from the baby's perspective. And so adding that, and I guess you talked about that already, is that usually, maybe not always, as soon as you add qualities or a cost for the infant, it trumps whatever the mom's utilities or cost or whatever it is.
But I just wonder whether, just my own understanding, I feel like the quality model could still fit, because if you're thinking about the maternal perspective, you've considered the mother who's going to be the full-time carer for that baby with a disability. She's taken that into account, and that is the combined health data. So isn't that...
You're leaving out the infant.
You're leaving out the infant, but it's from the maternal perspective. It's better than not including the infant at all.
But you yourself said these examples all have more than one. Like, that's one of the main reasons you said that clinical decision analysis is good, because you can take into account more than one person. I mean, yes, you can give a partial answer to that question, but the truth is, it's the baby, it's the mother, it's the supporting social environment. All of those are heavily at play in maternal-fetal decision-making. And to just partition one piece of that means that you're doing an injustice to the problem as a whole.
Yeah. Yes.
Can I get you going on a slightly, might be provocative issue?
Yeah. I love provocative.
I followed you most of the way, and the problems, particularly utility analysis and so on, but when you reach the point of whatever the best evidence available is, and I agree that there's lots of room for bias there as to what you're going to tell the patient, but if you can do that, why should the physician have anything to do with the decision, whatever?
Well, it's an interesting question. It is provocative, but so I trained in India and then in England and then here, and it's interesting. In India, most of the decisions were made by physicians because patients came to the doctor and just said, "I have no idea." It was very paternal that you do whatever you think is the right thing to do. Yeah. As physicians, we were the custodians of health, so that question really didn't get asked there. In fact, a lot of my invitations here, they say, why do doctors keep telling me to make a choice? Because I don't know. Aren't you the expert? So, I mean, there is that element to it. So it's not, I mean, there is an important role. And so we gathered a group of patients together, and there's another person who I met at a meeting not so long ago who did this study with, I think a student was Vidhi Thakkar. I don't know if any of you here know her. And what we found was patients do want physicians to be involved in decision-making, because there is a limit to how much they can understand and the implications of what they can understand. There is also the concept of the understanding of risk in the long term that they haven't fathomed. And therefore, they really do appreciate input and advice coming from a physician. So the model which only involves a patient making decisions is not one that is preferred by most patients. It is a shared decision-making model that involves them both making decisions. An interesting application of this decision analysis was done in Brazil, where a physician was treating a person with bipolar disorder, and she was trying to make a decision on whether or not she wanted to continue taking lithium in pregnancy, which is known to have fetal abnormalities. And so what they did was they came up with preference values. The probabilities were there, but preference values for that woman. They plugged that into the model sitting there, and it showed what decision she should take, and that she should take the lithium, and then she went on and took lithium. And so there was the use of a decision analysis model by the bedside. So, and that one is, shared decision making. So there is definitely utility for something like that. But I don't know. I don't know whether I've answered your question, but there definitely is value in guiding a person who is completely naive to a condition and to what might happen as a consequence of the condition.
Yeah, no question. Very reasonable points you're making.
Yeah. Other questions? Yeah,
can I take you back to the very first image that you showed, which was that evidence pyramid?
Yeah.
And you asked the question, where is decision analysis on this? So you're now at the end of 4 years. You're a wise practitioner of decision analysis, an advocate of decision analysis in the OBGYN community, a passionate evangelical advocate, perhaps. So now, if you were to redraw this evidence pyramid, like how would you do it?
Well, I would discard that pyramid completely. I think it makes no sense. It really is. It is, in obstetrics, it's so difficult to put these things, to kind of make sense of that kind of pyramid. Randomized control trials might be the best ways of answering some questions. But a lot of very, very, very good information in obstetrics has come from case control studies and from cohort studies and from case series and case reports, and we all know that. And so there is a value for every type of studies. It's about matching the study design to the question. And therefore, I don't like that pyramid because, yes, a randomized control trial does answer many questions about interventions, but it still has got its flaws. So I am not in favor of that pyramid. I think every study has got a role to play, and it needs to kind of match the research question that's being asked. And I think in obstetrics, the screening and prevention, I don't think anybody does the role of decision analysis. All of our HIV screening, syphilis screening in pregnancy, most of our antenatal screening has come from decision analysis work that has been done in the past. So I think with screening and prevention, there is no question that it's very high up there. And in the population, just like with other population-based studies, but for population-based conditions, but with management, I think people have a problem trying and trusting the model over things. I still think if we work these problems out and we use expected utilities as the final outcome, there still might be some merit in doing this. Yeah. And I don't know about cost. I was talking to Marina the other day, and we said we will try and add a cost aspect to this at some point once we figured out how to do the decision analysis, and that adds another level of complexity. And so I don't even know how we're going to tease that out right now. But I think decision analysis, I'd like to separate that from the cost effectiveness thing, and I think it still can have a very, very important role to play in many of the obstetrical decision making scenarios. I don't know if I've answered your question, but I think it's important. I just don't know where. I don't think there should be a pyramid. It should be a circle.
Do you think it belongs in the same category as those other things? Because those other things are evaluations of types of evidence,
right?
And decision analysis is an integrative method for bringing together different types of evidence. So in some ways, it's my view of that.
Right. I feel ultimately the reason why we do all this research, or why we should do all this research, is in order to inform clinical practice and policy. And so these are all means to an end, and they are all means to doing that. And if a randomized control trial can very clearly answer what is the right antihypertensive to use for somebody who has got high blood pressure, then yes, a randomized control trial. But if for some other conditions like mechanical heart valves, I don't think they've attempted randomized trials in the 1990s, and there's always this call to do randomized trials, but nobody's willing to randomize because physicians very firmly believe one thing or the other. And so it's never going to be the right method or the best method for that question. It's going to have to be decision analysis, which Anand will, and Marina and the rest of us are going to do. Yeah. Yeah. Sorry.
So this idea of the 0 polys for a baby that dies during labor, so do these studies ever look at, well, if that baby dies, the woman might have a baby later if she survived, so that baby will have a full life. So you've got 0 polys for this labor, you've got a full lifespan of polys for another baby.
Yeah.
So is that ever taken into account? Because it seems that it's very simplistic to say, well, potential life is totally lost.
Correct.
Therefore, that's worse than having a baby with severe disabilities live for 30 years.
Right. And we found that even with our study, I mean, I don't have an answer to the question, but what we found was if somebody had had a miscarriage before and then had a live baby, the value that she assigned to a miscarriage was very different because now she had had a live baby. So it was, but somebody who had never had a miscarriage before assigned a different value, and someone who had 2 miscarriages and no live babies assigned a very different value. So yes, the having another baby in the future might, but then that again brings me back to that question about, so ultimately all of this is from the perspective of the mother. right? And that is why, and that is the way, it's the only way it really can be, I think, because if you add the perspective from the point of the fetus, that fetus who died doesn't care about whether he's going to have a sibling, so it's going to still be zero. So I just feel adding the fetal perspective, I know there are no neonatologists in the room, but I feel is, I wouldn't say wrong, but it doesn't feel, I don't know how you could do that. Yeah.
Do you worry about if you were to add the fetal sort of perspective in societies where, like Alabama, for instance, a woman could be compelled to go through a therapy because the fetus suddenly has much more value than the mother does. And so this model, by keeping it purely from the perspective of the mother and incorporating the mother's loss in quality of life if there was an adverse outcome or a fetal loss, was really protective from her being potentially coerced to expose herself to risk if it's better for the fetus?
Well, yes. I mean, I had a chat with a feminist as part of my initial thing, and then she asked me, I went to London, and she sat with me for 4 hours and wanted to be on my thesis committee, and she was really, we talked about all these things, but I think the topic of fetal preferences and fetal, whether the fetus is a person and the fetus can make preferences, is something that differs in the law and in ethics and morals, and they don't always meet. In the UK, where I practiced, at the age of viability, that is at 24 weeks of gestation, the fetus got rights. The fetus had rights because the fetus was considered a person, and that's why there's that importance given to that number 24. So 23 weeks and 6 days, the fetus is not a person, but at 24 weeks, the fetus becomes a person. And so you are now looking after two patients, the mother and the baby. And if the mother is making a bad decision on behalf of not taking the baby into consideration, you as a physician are allowed to overrule that decision. And so there are lots of implications to that kind of a model. It seems right in some ways, but you could strap a woman down to a bed, I'm just exaggerating here, and do a cesarean section to get a baby out, even against her consent, in the interest of that baby, and then take the case to court the next day. And that doesn't really always happen, but technically that is what the law would allow you to do there. Here, the fetus is not a person at any point in time, not even when the baby's head is expelled and the rest of the body is not. It's a person only when the entire baby is out, and so can only have preferences at that point in time. It's just a different concept, and that is why a woman has the right to choose whether or not to have a cesarean, whether or not to terminate, and all of those things. And so there are a lot of ethical, moral, what is right and what is wrong, and I just feel in the North American society, or in this current climate where the fetus is not considered a person at all at that point in time. I know it's going to, once it comes out of the mother's womb, it will be a person. Understanding fetal perspective or adding fetal perspective or fetal values is just something that I still struggle with. I just don't know. I don't know what the right answer is. I just don't know. I don't know if anyone else has any thoughts on that. Karen.
What happens to these women that you did use for your utility study? Have you followed them up? Like some of them must have given birth to healthy babies, to dead babies, or to deformed babies. You should look at the bed maybe and get the utilities. You can get the utilities for the kids when they're 3 years old.
Right. So there is a study that's been done out of McMaster, not just 3 years, they've done for 29 years. So what they did was they started doing the studies with FRCOG, very interesting. She's written a book now. She put all those papers together and there's a book. And what she looked at was for very severe growth restriction, she got utilities from mothers during the antepartum period. And then when that's mothers that had babies with growth restriction and that had well-grown babies. And then got preferences again from them after the babies were born in the postpartum period. And then followed these children up till now they are 29. So she's still doing that. And a lot of very interesting things that come out of that. Essentially, not anything that we would not expect. Mothers' utilities remain constant in the antepartum and postpartum period, regardless of the outcome of the pregnancy. And so that was kind of reassuring. Their outcomes remain constant even as they were followed through the years. Children's utilities were much higher than the mother's utilities of the condition. They did not care about their disabilities as much as mothers cared about their disabilities. So there was that kind of a difference. And as time went on, their preference values to these utilities actually became a little better because they grew to live with that condition. They didn't see it as much of a problem. So yeah, there were a lot of that's been done before, and so we didn't do that yet. But I was interested in doing a utility study on congenital abnormalities, but the problem is the range of severity. Yeah, some of those abnormalities, because when you see a cleft lip, it could be just a cleft lip, but then there could be a cleft lip and palate, and there could be a cleft lip and palate on both sides, and it could be an isolated and not isolated, and then it just becomes very murky. And getting utility values from people with these disabilities is not easy. It's just very, very hard, because they really are not interested in talking to you about doing standard gambles. Yeah.
Any other questions? No? Well, then I'll ask us to thank our speaker again. Round of applause.